Next, we are going to focus on genetics and fertility. These are topics of concern for many NET patients and their families, and we get a lot of questions about these topics. Dr. Mark Lewis will discuss genetics, and Feighanne Hathaway, a genetic counselor from University of Chicago Medicine, will talk about genetic testing, what it is and what it can tell us.
Hello everyone, my name is Dr. Mark Lewis. I'm the Director of GI Oncology at Intermountain Healthcare based in Salt Lake City, Utah, and I'll be speaking today with Feighanne Hathaway from the University of Chicago on the subject of genetics and fertility, and I believe I get to lead off with a discussion of genetics in NETs. So the first thing to point out is that I think there's a lot of confusion between the term genetic and the term hereditary. What I'm interested in primarily in this talk is talking about the rare or few cases of neuroendocrine tumors that are actually a result of hereditary mutations. So what you have to realize is on some level, all cancer is genetic. All cancer arises, we believe, from a mutation or an error in our genetic code. What we're talking about today, though, is those instances where that mutation is actually inherited from one of your other family members. So for reasons that will become quickly evident, I'm going to use multiple endocrine neoplasia type 1 as an example. So what I'm trying to show you here is that the human genome, our genetic code, is 3 billion letters long, and to an almost frightening degree, a tiny mistake in that long sequence of letters, A, C, G, and T, repeated over and over and over again, can give you genetic conditions. So multiple endocrine neoplasia type 1, we've known since 1997. This condition, which I'll explain more in a minute, is actually arising from mutations in only a 7,000 or so letter sequence on the long arm of chromosome 11. So we have 23 pairs of chromosomes, and this occurs on the 11th chromosome. So again, what's really the issue here is the mutation occurring only in the tumor, what we would call a sporadic mutation, or is it actually occurring in the patient? So one example I would give you from math, I've been teaching my son algebra here recently. So every square is a rectangle. Not every rectangle is a square. What I mean by that is, as I said earlier, all cancer is genetic. Not all genetic mutations are hereditary. So what we're interested in here is parsing out, is the mutation only occurring in the tumor, sporadic, or did the mutation actually come from the patient's parents? And the reason I picked MEN1, if we look at pancreatic neuroendocrine tumors and take all comers, about 40% of PNETs will contain the MEN1 mutation. However, only a tiny fraction of those actually reflect the fact that the patient themselves has the MEN1 syndrome. So this is something called the two-hit hypothesis. This was first discovered or postulated by Dr. Knudsen. And it's one of the key things to understand is that if you've got 2 copies of every gene and you inherit a faulty one from one of your parents, you have what we call loss of heterozygosity. And that means you're basically living on a thread. You're living on the good copy of that gene until it in turn gets mutated somewhere in your lifetime. And that's how MEN1 patients in particular develop tumors later in life. Okay, so now I'm going to move quickly through a variety of hereditary syndromes. Again, each one of these is pretty rare. Multiple endocrine neoplasia type 1 affects maybe 1 in 20,000 to 30,000 families in the United States. It's an autosomal dominant condition. I'll explain more of that in a minute. And it's really recognized by the 3 Ps. So the 3 Ps are pituitary, thyroid, and pancreas, the 3 glands that are most affected. 3P mnemonic is great, but it doesn't capture some of the other, frankly, more deadly forms of this disease where MEN1 patients are also prone to develop carcinoid tumors or sometimes neuroendocrine cancers in their chest, whether it comes from the lungs or a gland behind the breastbone called the thymus. And then finally, and almost cosmetically, one of the key features of MEN1 is these little red bumps on the nose and the midface that can be quite painful and they can even bleed. They're called angiofibromas. So all told, if you add up in the pie graph on the right, you'll see that the vast majority of MEN1 patients fall into one of the 3P categories. But there are these rarer manifestations that can be easily missed even by very experienced doctors. And so again, think beyond the 3Ps when it comes to MEN1. So MEN2 is actually a completely different syndrome coming from a mutation on chromosome 10. It does bear some similarities to MEN1 in regards to hyperparathyroidism, but otherwise it looks completely different. So MEN2 has 2 distinct variants. MEN2A is medullary thyroid cancer, pheochromocytoma, and the hyperparathyroidism. MEN2B is the medullary thyroid cancer, pheochromocytoma, but then it has some very distinct facial features. So specifically, we're looking for bumps around the mouth and on the tongue. Finally, we've realized in the last couple of years that some patients actually have this sort of combination of the two syndromes, and it's called MEN4. And again, what was happening is patients were coming to us and they looked like they had MEN1, but when we just examined that MEN1 gene, which again is on chromosome 11, we didn't find anything. And the reason for that is there's actually a completely separate mutation that occurs again on another chromosome. And now we're talking about chromosome 12. So what this shows you is that MEN1 and MEN2 basically are spliced together here to form MEN4. These patients are affected by primary hyperparathyroidism. They're prone to pituitary tumors, but they also get the adrenal tumors like we see in MEN2. And then finally, they can get carcinoids in peanuts, and women can even get a very aggressive form of cervical cancer. So moving along, von Hippel-Lindau syndrome, sometimes known as VHL, again is autosomal dominant and occurs on chromosome 3. Here are the manifestations of VHL. You'll notice that the non-eponym version of this is not exactly something that rolls off the tongue. Familial cerebelloretinal angiomatosis. Basically, this means that you can get these very vascular tumors happening everywhere from the eye to the part of your brain that controls balance, to down your spinal cord, to your adrenal gland, to your kidneys, and even to your pancreas. The last couple of years, in fact, there is a medicine that is specifically approved, it's called belzutifan, for patients who develop tumors from VHL. So it's a landmark approval by the FDA because now we have a treatment that is linked to a genetic syndrome. And at least in my GI oncology practice, that's one of the first times that's happened. So what about too much adrenaline? So it turns out you can have too much of a good thing if your adrenal glands, or sort of the conduit of cells that produce adrenaline elsewhere in your body, if they become mutated, you can get something called a pheochromocytoma, often shortened to pheo, or a paraganglioma. And the top three ways this manifests in patients are really severe headaches, and usually at the same time, sweating and the pulse racing. And that triad tells us that there's too much adrenaline. So what I'm showing you here is most adrenaline in the body, as the name would suggest, comes from the adrenal glands. But about 10 or 15% comes from this chain of adrenal-like tissue that can occur elsewhere in the body, and those are called paragangliomas. Anyone who has a pheochromocytoma or paraganglioma should undergo genetic testing to rule out a family of mutations that we call SDHX, or succinate dehydrogenase mutations. Okay, I promise we're getting to the end of the syndromes, then I'll get into some more general points. So neurofibromatosis. So what I'm showing you here are three different aspects that you can see visibly on the surface of a patient that has neurofibromatosis type 1. So the top right, what you're seeing there are what we call cafe au lait spots. So almost like you've spilled coffee on the skin. You get these brown, pretty flat areas on the skin. We have a zoomed in picture of an eye, and what we're showing you there are what are called Lisch nodules. These little bumps that happen on the iris. So sometimes a good ophthalmologist will pick this up. And then finally, the neurofibromas of NF1 are these usually benign sort of nerve tumors, but if you look at the bottom right, they can be absolutely profound on the surface of the body, and as you can imagine, it can be quite disfiguring. So I'm happy to say over the last couple of years, we have some new treatments that also address those tumors. So tuberous sclerosis is interesting because it can actually come from two different mutations, depending on which chromosome you're on, chromosome 9 or chromosome 16. And again, remember, there's 23 pairs of chromosomes in all. So what I'm showing you here are all the visual manifestations. So there, you can see top right, there's a pearless patch on this person's back that's called an ash leaf spot. In the middle, there's a leathery appearance to the skin that's called a shagreen patch. And then finally, this name is right on point, it's called a forehead fibrous plaque. It feels like kind of almost like a raised scar on the forehead. And all of these are the skin manifestations of tuberous sclerosis. Finally, though, and relevant to NETRF, these can cause neuroendocrine tumors, and specifically in the pancreas, and they can look quite cystic. We're going to get out of the weeds and take a 30,000-foot view. Why does this all matter? So if you know a given patient has a genetic condition, they're going to have that the rest of their life, and that affects how you follow them. So for instance, for an MEN1 patient, I'm very, very eager to minimize their radiation exposure. I don't want them getting CTs every year because over time that adds up to be a lot of x-rays. So I prefer MRI for most of the patients I'm following lifelong with these conditions. So the tip of the iceberg phenomenon. Because of the inheritance patterns of these syndromes, if you can find one person who's affected, you can find multiple other family members. My best example of this is when I was training at the Mayo Clinic. I identified for the first time in a family a grandfather had MEN1. There's a large family, so when we went and tested all of his relatives, sort of a cascade, we found the full half of them, so 20 people out of the 40 people that we tested had MEN1 as well. And that, of course, is going to affect how they are followed by their doctors. So again, it doesn't just matter for the person in front of you, it matters for their whole family. Okay, so finally, as I was mentioning earlier, you can see some uncommon presentations of even rare diseases. So this x-ray holds a lot of meaning to me. This is the x-ray of an MEN1 patient. You do not have to be a doctor or radiologist to see the problem here. So the top right, remember this is flipped, so what's on your left is actually the patient's right lung. You can see this huge mass up in the top of the right lung. This is my father's x-ray. This is the x-ray he received when we immigrated from Scotland to the United States as part of public health. Everyone coming to this country gets an x-ray to make sure they don't have tuberculosis. My dad didn't have TB, but he had this huge mass in his lung that he didn't know about. So this is one of the manifestations that does not fit in the 3P mnemonic. This is a bronchial carcinoid, and this ended up killing my father. So you might imagine it makes me a little bit emotional, to say the least, to recognize that not all of these patterns necessarily fit nicely in things that we can remember. So just know that if you have a feature of a syndrome that fits outside the mnemonic, that's still very valid, and you can still bring your concerns to your doctor. So let's finish up with a pedigree. So a pedigree is what we call basically a medical grade family tree. So I'm showing you here is my own family. And I've started at the top by saying family history is never non-contributory. I put that in quotes or maybe even air quotes. That's something that you might see in your medical record. And generally what it means is your doctor didn't even take your family history. But in oncology, it matters a whole lot to know with as much detail as possible what affected your relatives and when. So looking back the way, I can see that my father's diagnosis, his high calcium level, which stemmed from hyperparathyroidism, and similar problems affecting my dad's side of the family, that was all MEN1. Although, frankly, I was the first person in my family to recognize that we had it, so this has all been reconstructed retroactively. So this is how I first learned about MEN1 in the textbook. It's classic autosomal dominance. What was happening here is a very astute doctor, an endocrinologist in New York City in the 1950s, was taking care of a family of Italian immigrants. And half of them were dying from stomach ulcers. Now that may sound very odd. Like, why would that be happening? The reason it was happening is that in MEN1, whether it was men or women, those unfortunate people who inherited the mutations from their parents, which you can see here, they're the squares and circles that are either blacked out or grayed out, those people had a predisposition to stomach ulcers that would either bleed or perforate, meaning create a hole in the stomach, and those were often fatal events. So prior to 1990 and the advent of drugs like omeprazole, the PPIs, Nexium, for instance, people were dying left and right of that particular stomach ulcer problem. So this is how I first encountered MEN1 in a textbook. And basically what it means is a 50-50 chance that you're going to get the syndrome if your parent has it. And this is how it looks to me now. These are my kids. So it's one thing to look at an abstract diagram in the textbook and say, oh, isn't that interesting? It's completely another when it's your life and it's your family. So I have two children. Happy to say you can't tell by looking at them who's got MEN1 and who doesn't. But this is my final illustration of 50-50 inheritance under the autosomal dominant model. My son inherited it from me, and my daughter didn't. And I'm okay with that, but I think as we get into the fertility discussions, I think this affects how people approach family planning, and specifically the area of reproductive endocrinology, and I'll defer to my partner to talk about that in the fertility section. But I just know this is very real to me. This is not diagrams and textbooks, this is real life. And the family aspect of it absolutely matters, but thankfully it's the minority of NET patients that actually have to deal with hereditary mutations. So in closing, I want to thank you. This is definitely a community that has supported me through some very difficult times. And I'd be remiss not to note that my greatest support has actually not come from a blood relative. It's come from my wife, who has literally sustained me through some of the darkest and most difficult days of my disease course. So on the left, you can see me in the morning of my Whipple surgery, where I had half my pancreas removed. In the middle, when I got out of the hospital a week later. And 5 weeks later on the right is when that tube was finally removed from my nose. And boy, that was one of the most joyous moments of my entire life. So have a great conference.
Hi, I'm Feighanne Hathaway. I'm a board certified genetic counselor from the University of Chicago, and I'm grateful to be talking to you today a little bit about the genetics of neuroendocrine tumors. For those of you that don't know what a board-certified genetic counselor is, we provide patients with a little information about what genetics is, how it plays a role in your cancer diagnosis. And so I'm going to explain a little bit about that today. So to begin with, all cancer is actually genetic. In order for you to get cancer, you have to have genetic changes occur. And when I'm talking about genes, and this is an example of our cell, in our cell we have chromosomes, and on the chromosomes we have genes. We have many different genes that do many different things in our body, including they make our eye color, our hair color. But what I'm referring to are the genes that actually, their job is to protect us against getting cancer. Those specific genes are called DNA repair genes and tumor suppressor genes. And if they're not working properly in our body, if we've inherited a copy from our parents that doesn't work properly, that can put us at higher risk for getting cancer. I'm going to explain this a little bit later on in more detail. So what is the big difference between when somebody gets an acquired mutation, so something that happens as they get older, and a germline mutation, so something that you're born with? So all those tumor suppressor genes that we were talking about, we get one copy from our moms and we get one copy from our dads. If both copies are working, that's great. And you can go through life, but then they can actually get knocked out as we proceed with life. Some people, though, are actually born with one copy already not working from either mom or for dad. So when we're referring to cancer genetics, there's two types of cancer genetics. There's germline mutations, and then there's also somatic mutations. And again, all cancer is genetic in the sense that you have to have genetic changes occur in order for you to get the cancer. And those are all somatic hits, or hits that are occurring within a particular cell that can actually grow out of control, and that's actually what causes cancer. So to give you a little bit more information about this, so tumor suppressor genes and DNA repair genes, again, we inherit both copies from our moms and from our dads. So we inherit a copy from mom, we inherit a copy from dad. As we get older, just by the normal aging process, some of them can get hit and knocked out. And in that particular cell, that gene is no longer working. But you have that backup copy, so you're okay. And as long as that backup copy is working, then you won't get cancer. But what happens when that backup copy also gets knocked out? Well, now you have no backup copy and you get the cancer diagnosis. So that's your typical sporadic cancers. Then on the other hand, we have hereditary forms of cancer. And the hereditary is you're already born in every cell of your body with a copy that's already not functioning. And so as long as that backup copy that works and does its job, you'll never get cancer. But what happens again if that one gets knocked out? Well, now you can develop cancer. So this process is actually the same as far as cancer development goes. It just happens a little bit quicker for hereditary forms of cancer. I've been doing this for about 20 years now, and the role of genetics has changed dramatically. When I first started doing cancer genetic counseling, we were looking at one or two genes at the most. We had to do testing. Testing could cost up to $5,000. Now we do testing, and we can actually do genetic testing looking at the tumor itself and also looking at your blood, so looking at germline genetics. My role has expanded exponentially. I'm really excited about it, and I think it's created many opportunities for patients to actually undergo different treatment options. But we can also inform family members about risk and also offer family members a reduced risk assessment. So what are these things that I'm talking about? Well, these are the three types of cancer that you can get. You can get what we call sporadic cancer. So that's someone who actually, if you see down at the bottom, who gets a breast cancer diagnosis in 60. So we know that, for example, in breast cancer, 1 in 8 women will get a form of cancer. And so when you get it in your 60s, that's considered a typical diagnosis, usually done due to the environment or random genetic changes that you've acquired. Familial cancer, the difference between that, makes up about 10% of all cancers. That's usually one generational. So you'll see this in families that might live in a hot spot for getting cancer. And so it's a combination of their genes and their environment, but you won't see the multiple generations. You won't see the younger age of diagnosis. On the other hand, then we have the hereditary cancer forms. This is where I come in. Most cancers do not fall in this, so only about 5 to 10% of all cancers actually will fall into this category. And it tends to be a younger age of diagnosis. So that goes, for example, for breast cancer, 45. For neuroendocrine tumors, it's also going to be around under the age of 50. So anything under the age of 50 is considered an early onset diagnosis. And then also the rare cancers. So in this example, it's showing you an ovarian cancer. Only 1 to 2% of the population will get an ovarian cancer. So when you see that, you kind of go, well, why is that? In the neuroendocrine world, a pheochromocytoma actually is considered a rare cancer diagnosis. So when we see that, we automatically go, well, maybe this person is at higher risk for a hereditary form of cancer rather than just the random sporadic cancers. So what are the hereditary cancer syndromes specific to neuroendocrine tumors? When we have a pancreatic and a GI syndromes, we have MEN1 and von Hippel-Lindau. And then when we have the pheochromocytomas and the paragangliomas, we also have von Hippel-Lindau, MEN2, neurofibromatosis. And then there's this new category of genetic syndromes called hereditary paraganglioma and pheochromocytoma syndrome. And I'm going to go into the details of this a little bit. Medullary endocrine neoplasm, MEN, is divided into two categories. We have MEN1, we have MEN2, and then MEN2 is actually divided into two more subtypes. MEN1 has a prevalence of about 1 in 10 to 100,000, and it involves two of three specific criterias: a parathyroid tumor, a pancreatic insulinoma, and a pituitary tumor. All of these conditions are what we call autosomal dominant, meaning males or females can carry these. It's about 90% inherited. So if somebody is diagnosed with this syndrome, they know that they probably got it from mom or dad. But then 10% is what we call de novo, meaning it could have just happened in the child at the time of conception. Mutations in MEN1 are typically just in the MEN1 gene, 95% of the time, but about 5% of the time we might not be able to find the genetic change. MEN2 and how this is different is a much higher prevalence, about 1 in 35,000. And these involve thyroid cancer about 95% of the time, a parathyroid adenoma, a pheochromocytoma. 5% of MEN2A is de novo, meaning 95% of MEN2A is inherited. The difference between an MEN2A and an MEN2B is that in MEN2B, it includes all the same cancers, but it has a specific phenotype. It's called a marfanoid-like phenotype, meaning that an individual can be taller than average, taller than their parents. They have a longer wingspan than typical, and it's usually because it actually affects their collagen. 50% of those are de novo, so that usually happens at conception, and some people don't even know they have this syndrome. So that's one association. The second association that we have is von Hippel-Lindau, or VHL. VHL is the actual gene that is associated with this particular syndrome. It has an incidence of about 1 in 32,000. It's also autosomal dominant, again, meaning mom or dad can carry it. And it has about a 20% de novo rate. These individuals are at risk for adrenal gland tumors, the pheochromocytomas, pancreatic tumors, kidney cancer. They can also have a retinal angioma, sometimes some brain tumors, and spinal cord tumors. Mutations in the VHL account for about 100% of all VHL. So usually if you have this disease, we can find a mutation that's causing it. The third neuroendocrine tumor that can be associated is a condition called neurofibromatosis. This is usually diagnosed actually in childhood. It has an association with pheochromocytomas, but typically it will have all these other clinical diagnoses like cafe au lait spots, Lisch nodules in the eyes, skin fold freckling, so under the armpits, and then many neurofibromas on the skin. You can have hundreds to thousands of these neurofibromas that are on the skin. So typically you see this in childhood. Then the newer category of genes is the succinate dehydrogenase syndromes. These can be associated with all of these particular 5 other genes: SDHA, SDHB, SDHC, SDHD, and SDHAF2. 1 to 10% of all sporadic pheochromocytomas and paragangliomas can be associated with the syndrome. And then about 20 to 30% of what we think are inherited can be associated, we'll be able to find one of these genetic changes. The clinical manifestations are, again, just pheochromocytomas and paragangliomas. To kind of go over what a pheochromocytoma is, it's usually a benign tumor of the adrenal gland, and a paraganglioma is a benign tumor near the nerve and blood vessels. So the signs or symptoms can actually be hypertension. You can usually sometimes end up with headaches, sweating, heart palpitations. So sometimes when I'm taking a family history, I usually will say, did anybody suddenly die in your family of a sudden stroke or heart attack? Does anybody have any panic attacks? Because all of that can be manifested in this particular syndrome. The red flags for neuroendocrine tumors is any diagnosis under the age of 50, and then any weird cancers. So that pheochromocytomas, again, it doesn't matter what age of diagnosis. In that case, we would automatically want you to see a genetic counselor to see if it's hereditary type. A paraganglioma by itself is also an indication. And then any diagnosis of any pancreatic tumor, whether it's a neuroendocrine tumor or not, is actually going to be warrant a genetic testing. So that's usually one of the number one concerns of a lot of my patients is, what about my kids? We do test children for all these conditions because screening for these conditions will actually happen at a very young age, even at birth. Can I avoid having a child with this syndrome? What is the risk to have this condition? So because this is autosomal dominant, all these conditions, that means that your children will have a 50-50 chance of inheriting the syndrome. So meaning you can pass on the one copy of the gene that's working, or you can pass on the copy that's not working. If you want to avoid having a child with this condition, you can go through a process called PGD, or pre-implantation genetic diagnosis. And what that involves is IVF, and they select the embryo that doesn't carry the mutation, and they put that in as opposed to the embryo that might be carrying that. So that's a way of avoiding having a child with the condition, or reducing the likelihood. And another way, obviously, is just to know ahead of time whether the child has the condition, is to do typical prenatal genetic testing. You can do that through amniocentesis, even if you just wanted to know upfront whether or not your child had it before they were born.